You're listening to the Cancer Assist podcast, hosted by Dr. Bill Evans and brought to you by the Cancer Assistance Program. Wherever you are in your experience, we're here to provide help and hope as you navigate cancer prevention, treatment, and care. Help when you really need it.
Well, welcome to the Cancer Assist Show. I'm your host, Dr. Bill Evans, and I'm really pleased that we're going to be talking about bladder cancer. You know, I think this is a cancer that hasn't got enough attention, and I'm really delighted that I have two specialists with me today, Dr. Lorraine Liang and Dr. Khan Lalani. Welcome, and I really am appreciative of the fact you're giving up some time. I know you're both extremely busy, and this is a time of year when you're sort of doing a lot of catch-up, so thank you so much for being with us. Now, Lorraine, you're a urologist at the McMaster Institute of Urology, located at St. Joseph's Hospital here in Hamilton. And you're an assistant professor, and you're one of the 6 urologists working in that institute. So it's quite a team you have put together there. And with you, we have Dr. Khan Lalani, who's an associate professor in the Department of Medicine and the Department of Oncology at McMaster University and based at the Juravinski Cancer Center. And again, I'm delighted you're both here to talk about bladder cancer. I often like to start by maybe asking a little bit about how you got to be a urologist. And so, Lorraine, to you, why did you choose to get into urology? Was that your initial idea of what you wanted to be when you grew up?
I think when I was little, I never thought about what was coming next. I just did what was in front of me. My parents had an ice cream store.
Oh, really?
Yeah. And, I grew up in that store. They took on a lot of, diet products, Atkins things, sugar-free stuff. I became really interested in nutrition. But then I went to school at Columbia and majored in visual arts because the guidance counselor told me, do what you like. So I almost ended up as an artist. And then afterwards, I was like, well, what will I do with my life?
Oh, I make a living.
Make a living. How do I make a living? How do I get healthcare? And I looked into, a master's of nutrition still at Columbia. And I thought to myself, I think if I'm a doctor, people will listen to my advice more than if I'm just a nutritionist. And so that started my long road to go to medical school. In medical school, I found that the medicine folks were a little bit put off by how direct I was, and the surgical folks were a little more comfortable with me. That kind of put me towards the urology surgery path. I did some really great research with some really awesome people in urology. My grades were good, and that's, kind of how I ended up in urology, attracted mostly by robots and lasers and the fun things that we get to do.
I was going to say, did you have a role model? And then you mentioned robots and lasers.
Robots and lasers.
Well, that's a very interesting career path, and one of the more interesting ones we've heard about on the podcast. Khan, can you match that?
Yeah, hard to top that one. I mean, child of immigrants as well. My all families in business, chartered accountants, so absolutely no medicine in my family before I also decided to go into medicine. It's funny, guidance counselors in elementary school said, you're left-handed, you're more artistic, so languages and music and arts will be what you do. And so I enjoy all that, but went into medicine. It's funny, I think I started actually being interested in procedural skills. So even though I was in internal medicine, I thought I'm going to be a GI doctor, I'm going to be a gastroenterologist, that's it. And then, I remember at the end of first year, I said, I did voluntary call with a fellow, like who does that? But I decided to do that with a fellow to understand GI better. And I said, this is cool, but at 2 a.m., do I want to be scoping someone in the ICU? And I said, I really should broaden my horizons a bit. And then anyways, oncology happened. I think the mix of personality and science, and then the rest is kind of history. So.
Well, it's great. I think you both ended up in a good place.
Yeah,
so thank you. Now, in bladder cancer, I was kind of struck when I did a bit of reading at just how common it is in Canada. Like 12,000 plus individuals diagnosed with bladder cancer annually in Canada. 5th commonest cancer. It's sort of been flying below the horizon in a way. We think about the big 4 cancers, the breast, lung, colon, and prostate, and don't think so much about bladder cancer. So we're way overdue to talk about it on the podcast. And I think it's more important than we've recognized. More common in men than women. But tell me a little bit about what are the risk factors for getting bladder cancer?
So the easiest one is going to be smoking, modifiable risk factor. Smokers are much more likely than non-smokers to have bladder cancer. Also, patients who have exposures to aniline dyes, used to be tanners, or I've had a lot of hairdressers with trouble. Patients who have had other cancers and treatments for cancers or chemotherapy and radiation exposures. Um, Unfortunately, a lot of our patients who've done factory work and been exposed to like smelting and smoke and that kind of thing. Also, for some reason, in patients who work in mechanic shops and things like that, just paint thinners and benzene, um, aromatic, like smelly chemicals.
So Hamilton being a place with a lot of manufacturing, steel smelting and so on, are we seeing more bladder cancer here than in many other places?
I think everywhere I've been, I've seen a lot of bladder cancer. But I think it's also, a function of what I do. And
Yeah.
so there is bladder cancer. I think there's probably more here than there would be maybe in Toronto. Sure.
You didn't mention age, the thing we can't control.
Oh,
But
yes.
as we get older, I guess we have greater risk of developing all cancers practically, but bladder cancer as well. Glad you mentioned smoking, being someone who's responsible for the program in the province for smoking cessation. I think a lot of people just think about lung cancer and maybe head and neck cancers with smoking, but there's about a dozen other cancers that are associated with smoking, bladder cancer being a prominent one. So it really is an important message to get out that people should stop smoking if they currently are or never start. This is the ideal situation to try and avoid things like bladder cancer, amongst others. Maybe just to ask you, Khan, just in terms of presentation, like how would someone be aware of or suspicious of something wrong that might lead to a diagnosis of
I
bladder
mean, it's a
cancer?
good question, and one that someone like Dr. Liang would be seeing a lot more as a urologist, but we certainly do hear this when we see them in medical oncology. We go back through the whole story, and it often starts with hematuria or blood in the urine. I was always taught in med school, painless hematuria in someone over the age of 60 is bladder cancer until proven otherwise, right? And so, when you think about where the lesion is and what it can, kind of result as or manifest, and thinking about the whole urothelial tract, we're talking about bladder cancer, but obviously the lining in the ureter and the renal pelvis are similar. So I would say, pain, blood in the urine is certainly one of the more common things that I would say in retrospect we see. Admittedly, by the time patients see a medical oncologist, it's muscle invasive or beyond. But these are kind of often times what leads to workup for a patient where they would see a urologist and have a full kind of view as to what's inside the bladder and beyond. And so these are unsurprisingly, as you said, part of aging, historic issues with smoking, although even on your own podcast, I think people have commented that these rates of smoking are dwindling now,
Right.
but that population that did that median age of being in the 60s in clinical trials is one thing, but we often see it in the 80s and beyond, even by the time they get to medical oncology. So it is an age issue, a smoking issue, and then obviously presenting as it might typically.
Right. Now, Lorraine, Khan mentioned blood in the urine, but how does that appear to a patient? Is it bright red blood they're looking for, or is it something else, or can it be a mixture?
So there's going to be a division between patients who actually see the blood in the urine and the patients whose family doctors get their regular annual checkup and there's just microscopic blood. Admittedly, patients who have microscopic blood have a lower risk, but it does exist. And so we do see a fair number of patients who feel nothing, see nothing, and their doctors are just sending them in because there is blood in the urine. And definitely we do see patients who have bladder cancer come in with only microscopic urine. It is rare, but it does happen. Patients who have blood in the urine that they can see, so wine-colored urine, rusty-colored urine, gross red blood with clots, all of this would be
So there's
considered
a whole spectrum
blood.
of
There is a
color.
whole
So
spectrum.
just looking for bright red blood wouldn't be the thing. A rusty looking urine is another sign thereof, or little clots.
Now, sometimes you've got patients who say, well, it's in the toilet. I don't know if it's coming from my bottom end or my middle or my front. Sometimes I only see it on the toilet paper. The evaluation for bladder cancer is, I think it's such that it's not so invasive and painful that it's reasonably worth looking, even if you're not sure, especially if there are other risk factors like we mentioned, age, smoking. family history of bladder cancer, that kind of thing.
So you touched on looking. So how does one look at the bladder?
So anytime we see a patient who has hematuria, blood in the urine, there are a number of tests that we do. We first check the urine itself, look for infection, look for cells in the urine called a cytology, and that just happens at the lab. And then depending on whether it's microscopic or gross, if it's microscopic, we'll start with an ultrasound, kidneys and bladder, look for things like kidney stones, masses in the kidneys. We'll look in the ureters and in the bladder itself. And sometimes you can see a mass on an ultrasound. Sometimes you don't. On a CT scan, you would do like a triphasic, so without contrast to look for stones, with contrast to see if there are any masses. And then you do a post-contrast phase where it actually waits for the contrast to come into the ureter itself to see if there are filling defects or things in the ureter itself that you wouldn't otherwise see without that third phase. And the last step would be the cystoscopy or the camera that goes in the bladder. This is generally done without an anesthetic, but we do put freezing jelly in the urethra. So for a man, that means we put the jelly in the penis. For a woman, it means we put the jelly in the urethra and we put the camera right in. Where we are at St. Joe's, there is a screen where the patient can see what I see. So if I see a bladder cancer, they're able to see it at the same time. And we point out different things, anatomical landmarks. And patients are usually quite tolerant of this procedure. Maybe 1 in 100 or so, gets very, very anxious. But we talk them through it. And it does take less than 5 minutes. A bladder cancer looks a little bit like a sea anemone because we're filling up the bladder with fluid and it kind of waves at you. And they're generally quite papillary if they're low grade. And so they're fun to see. Less fun to be on, the receiving end
As
of the news.
a patient, maybe not so fun to see, but interesting.
But they don't mind seeing it if it's there. For the lower grade ones, 80% of them do end up being lower grade cancers. They're a little bit prettier. The ones that are higher grade or muscle invasive are often quite a bit bigger. There can be some associated bleeding when you're looking at it. Sometimes there's got like little stones on it. So those are a little bit less pretty, but we identify by looking.
How do patients react to seeing things on the screen as you're doing it? Like, do they feel reassured by visually seeing it? And how do they react when you point out, well, there's actually a cancer here?
Some of them feel relieved that they know why they're having the symptoms that they are. A lot of times, and often women get diagnoses later because sometimes patients go and they say, I have blood in the urine, and they're treated again and again for bladder infection, and the cultures come back negative. And the women are like, well, what's wrong with me? Why does this keep happening? And when you show them a cancer and you tell them what the next steps are, often they're quite relieved because they think they're not crazy anymore, or they realize they haven't been crazy this whole time. Yeah. There are some who freak out, but I generally do prepare patients that this is what we're looking for. And if we find this, then we will discuss the next steps. And so usually if you're prepared and you're talking and the patients are engaged, the comfort level is better. And then we go as we take things as they come. And patients generally do quite well.
Let's take the situation of a very superficial kind of cancer, which I think are the more common things in presentation, right? So what do you do then? You've observed it. At the same time, do you go ahead with the procedure, or is that something you have to prepare the patient for and do it a second
If the tumors are super, super small, and this is pretty rare, and they're amenable, I can just take a biopsy at the time of the diagnostic system, burn the base, send it off the pathology, and see. If we're pretty confident by looking at it that it's going to be like a low-grade superficial, I don't have to go much deeper. If it is bigger, like a centimeter or 2, or between 2 and 5, we would get them ready. We would consent them for surgery. We would find them a time for surgery, and we would go in. Usually you go to sleep or you get a spinal, and then that's a general anesthetic or a spinal anesthetic. So it involves an anesthesiologist and, pre-op clinic and that kind of thing. And we go in through the urethra again. We use a cautery loop. So it's like this really neat little wire, and you scoop out the tumor, try to take all of it out and get a nice big bite of the muscle to make sure that there's no tumor in it. Then you stop up all the bleeding, and then the patient generally goes home the same day.
And when you scoop up the tumor, do you put it into anything, or is it just pulled out through the urethra?
So the camera scope that we use for the resection is a little bit bigger, and that sheath stays in the patient, and then the loop can come out so that the tumor can come out through the sheath, so it's not touching all the other parts of the patient as it leaves the patient.
Now, are you concerned about cancer cells that are broken loose and are floating around in the
Yeah,
in the
so
urine?
usually we make sure that we get all the pieces out and we burn it all up. Sometimes, if we already know that it's a low grade or if it's multifocal, we can give them a single dose of chemotherapy at the time of surgery within 24 hours. That would be your post TURBT first dose within 24 hours. It would be a mitomycin.
Hmm.
That one can sometimes cause you to have a little bit of irritation when you pee. Um, we do drain it out of their bladders before they leave, and they have to be disposed of in a certain way. Sometimes it's a little bit hard to get if you don't prepare in advance, but we do our best. If we're not sure if it's a low-grade cancer, if we think that we've resected a bit deep, we generally don't give that post-resection dose.
Okay. Now, why do you put chemotherapy in at all?
Well, we give it so that it doesn't come back as soon or at all.
Because there is a risk of recurrence, right?
There is, yeah. So
When it's-
bladder cancer, I explain to my patients when they're low grade that while it is cancer, generally it's kind of annoying like a pimple. And so we remove it and then we keep an eye on it to make sure it doesn't come back. Generally, they do tend to come back. The sooner they come back, the more we worry, the more other therapies they're offered. If it's just a small tumor and we've gotten it all and we look in 3 months and it's not there, then we continue to look with the hopes that it doesn't return.
And the frequency of looking every 3 months? Or
So for the low-grade cancers, I like to look 3 months after the first time, and after that, we space it out between 6 and 12 months, depending on whether they recur or not.
Right.
I like to keep them forever. If they start to get kind of antsy, then we can negotiate
What's negotiation?
how frequently we look.
Yeah.
I have some patients in their 90s. They're starting to have dementia. The family members are noting that they're getting agitated
see.
before coming,
Yes.
and then we negotiate. But
Right. Okay.
for healthy people who have reasonable
Quality of life, you want to make sure it's not coming back. So the frequency is kept more rigid, I guess. Eh?
I like to see them once a year at least,
Yeah.
once they're 3 years out.
So those are for the more superficial and more easily managed, but do tend to recur. But you talked about muscle invasion, so maybe we need to get into that area. And what's the concern about muscle invasion? What does that portend?
So muscle invasive bladder cancer is a little bit of a different beast. Once it starts to invade past the lamina propria into the muscle, the likelihood of it spreading is much, much higher. And that's where Dr. Lalani kind of comes in. When we have muscle invasive bladder cancer, we like to take out the bladder, but generally patients do better with a radical cystoprostatectomy or a cystectomy when they've had chemotherapy first.
So let's talk about that a bit, because that's now sounding much more challenging when the bladder's coming out and there's chemotherapy beforehand. And so the selection of the patients that you choose, and then what's the chemotherapy look like in terms of side effects and things like that.
Great questions. And I would just say probably a big theme is that it is truly multidisciplinary care. And I liken it to the baton being passed between the right specialist to help the patient in the time. And as Lorraine mentioned, I mean, these patients have had often a relationship with a uro-oncologist, and we certainly want that to continue. But they are reaching out to say, hey, this patient needs some systemic treatment potentially before we do something to the bladder. And so just a quick shout out for our multidisciplinary bladder cancer clinic that we have at the Juravinski Cancer Center. And if you'll permit me, just the lay of this clinic is that every patient with muscle invasive bladder cancer, theoretically in our catchment area or region, can be referred to this clinic, where the patient would see a surgeon if they haven't already, but if they have a uro-oncologist, they would remain the uro-oncologist of record if it makes kind of the most appropriate sense. They'll see a medical oncologist and a radiation doctor at the same time. And so to your point, at that visit, we get a chance to, three heads kind of come together to revisit the file, start from the whole, when did this present with perhaps blood in the urine, how many treatments or things like BCG or other things that they have in the past, and then say, okay, it's now muscle invasive, so let's look at what we can do. And as you've mentioned, the standard of care really is to do chemotherapy, what we call neoadjuvant chemotherapy or treatment prior to definitive management, before going on to that definitive management. So from a medical oncology perspective, we take the baton at that point. Our job is to make sure the patient is cisplatin eligible. So there's medications like cisplatin and gemcitabine given through an IV, done for about 4 rounds or 4 cycles of treatment. at which point I often book a CT scan at that point to be done after treatment. We make sure the cancer is not spread anywhere. And then the baton goes back to the uro-oncologist to look inside and say, how are things looking, where we previously saw muscle invasion. And then a critical decision is made for surgery, which is the majority of our patients do get surgery, or in those who might have been extreme responders and have a very good benefit, to get radiation as definitive management with any limitations that come with radiation. But that's where that bladder clinic comes in handy, because the patient can be seen back there. All the principles are there. And of course, there's lots of reasons why a patient might be benefiting from radiation, or unfortunately, some patients aren't surgical candidates or can't get chemotherapy. They go on to radiation. But in general, I think the big takeaway is neoadjuvant chemotherapy and then reassess for a potential surgery.
Before we talk a little more about that, I think we'll take a brief break and hear from our sponsor, so to speak, from the Cancer Assistance Program, and we'll be right back to talk more about bladder cancer.
We'd like to take a moment to thank our generous supporters, the Hutton Family Fund and Banco Creative Studio, who make the Cancer Assist podcast possible. The Cancer Assistance Program is as busy as ever, providing essential support to patients and their families. We remain committed to providing free services for patients in our community, including transportation and equipment loans, personal care and comfort items, parking, and practical education. These services are made possible by the generosity of our donors through one-time gifts, monthly donations, third-party fundraising, corporate sponsorships, and volunteer opportunities. Visit cancerassist.ca to see how you can make a difference in the lives of cancer patients and their families.
Well, we're back talking about bladder cancer, and we got into muscle-invasive bladder cancer, but we want to also just talk a little bit about the difference between low-grade and high-grade cancers, because there's a difference in their management, and we meant to talk about that a little earlier, so we'll talk about it now. So, Lorraine, that's one of the important things when you send a specimen off to the lab, you're going to be looking at in the report, because that's going to determine whether you do something additional, I think, for that particular patient with a higher grade cancer, right?
Sure, Bill. So when we get the pathology back from the pathologist, the result, we're looking to see low grade or high grade, just as you said. We're looking for depth of invasion, which we kind of touched on before. We can get high grade bladder cancers early, and those can be superficial. So if they're, not quite invading the lamina propria, then they would be considered eligible to have intravesical therapy or therapy inside the bladder, rather than going to Dr. Lalani for something that would go in through an IV to affect the whole body. Generally, what we do is we send people for BCG therapy, and BCG is what they used to use to immunize people against tuberculosis.
Right.
And so instead of injecting you, they put in a catheter and they put the BCG into the bladder, and it forces the bladder to react, because this is an irritant, and to try to kill any cancers that are there and to prevent the cancers from coming back. It can be pretty irritating to the bladder, and it feels like a UTI, and patients often feel like, they're peeing all the time and urgently. But generally, the people who have that reaction actually have a better response from the BCG from a cancer standpoint. And so if you're miserable, I guess it's worth it because it's working. What happens when you're getting the BCG is we do monitor you frequently to see, has the cancer come back? Is this working? And if it's not working, there are some other intravesical therapies that can be tried. Some of them are available, some of them are not, where we're working. Or we would then send you on to have a talk with Dr. Lalani's group, or we would re-resect you and see if there's any sort of depth of invasion that has changed.
Good. Well, I'm glad we picked that up. Maybe we should also, because we've got people listening who are non-medical, when we talk about high grade, what are we really saying? Like, what do we mean when we say high grade versus low grade? What is it the pathologist is seeing, perhaps?
So I think they're looking at the numbers of nuclei and how
abnormal the cells look, and it looks like they're rapidly growing.
So if they're more abnormal looking or less differentiated, they tend to be more aggressive. And so they use certain markers to identify whether or not patients will likely go on to have metastases or likely go on to have more depth of invasion compared to a lower grade, which will continue to be like this pimple reappearing in the bladder that you just scoop out and move on your way. Which is to say, if you ignore the low-grade ones, they can grow to be quite large and cause bleeding and obstruction, and then you can't pee. So you shouldn't ignore them, but they're unlikely to kill you.
Right. That sounds very definitive. Now, what else is definitive? You were talking about preoperative chemotherapy. So we've got preoperative chemotherapy for these muscle invasive cancers that require then a cystectomy. So then they're over to the urologist like yourself, Lorraine, to do. And it isn't just the bladder that's removed at the time of that surgery, as I understand. Is that correct?
Correct. So I'm no longer doing cystectomies because I've kind of decided that that's going to be less a part of my practice. Patients who get cystectomies should go to surgeons who are doing them quite often because they'll get a better outcome. The more you do, the better you are. And so when I decided not to do them, I decided to support my colleagues who are doing them so that the patients can get a better outcome. But when you are a man with bladder cancer that needs to be removed, they remove the entire bladder, the prostate, and usually they take a bit of small intestine and either connect it to the body wall so that the urine can come out into the bag, or they can create a neobladder, which is a bit of a sphere. It's arts and crafts. It's actually quite lovely to do. I do miss it. And connect it to the urethra so that you can still pee out of it. So it's a very, very big surgery. And then they take, of course, lots and lots of lymph nodes to make sure there's no spread, which is very important.
And for a woman, what's the...
For a woman, when they're
cystectomy look
taking
like?
the cystectomy, so they're taking the bladder, often they're taking the uterus as well as a cuff of the vagina.
So these are big procedures, and they must have some significant morbidity and maybe even risk of death from the surgery.
So it is a highly morbid surgery. I think 30% complication rate, including things like infection, DVT, PE,
Pulmonary embolus for PE.
So clots in the legs, clots in the lungs. You can also get strictures or scarring down in the ureter where you're connected to wherever you're putting it. You can get ileus, meaning the bowel is really slow to wake up after surgery. Oftentimes, you can get different things.
Well, you made a very good point about having that kind of surgery done where a lot of that surgery is being done, because it is true that in surgery, the more someone does, the better they are at doing it. And so to anyone listening out there who's either scheduled to have one or knows someone who might be scheduled to have one, it really is important to get to a place like the St. Joe's Urology Institute where you've got people who are doing them all the time. If you're listening from some other part in the world, then it's important for you to make sure that you get to individuals who aren't just doing one every once in a while, because this is an important and a big operation, and you need someone who's very competent to do it. And not only the surgeon doing it, but the team behind them that's there to support you post-operatively and make sure you recover properly. So all those things are very important and when you're undergoing major surgery. Just as it's important to have a team around you when you're getting systemic therapy. And the drugs that we're using these days are increasingly interesting but complicated and have unique side effects. Not that many people present with what we call stage 4 bladder cancer, but it's not zero either. From the stats I saw, maybe 8% or something present with what we call stage 4 disease, which would be directly, I guess, to a medical oncologist, wouldn't it?
Yeah, in general it is. And this is still where our bladder clinic comes in handy. So as mentioned, I know we're going to get to stage 4, but for those patients who have had a surgery and they may or may not have had chemotherapy prior, there might be some findings on that pathologic sample. So when they look at the tissue for a size or stage of the cancer and lymph node involvement, there might be a reason folks would get adjuvant therapy, which is insurance policy, reduce the chance of it coming back in the form of immunotherapy. So there are patients, and this is where our bladder clinic is super helpful, who could have the baton go from surgeon to medical oncologist for chemotherapy, back to the surgeon, obviously do that definitive management, curative intent, and then back to the medical oncologist to give immunotherapy after surgery, all around what we call perioperative setting. So I totally echo what you're saying. Make sure your team is very experienced in bladder cancer, who's looking after you. Unfortunately, some of those patients, despite all of our best attempts, do at some point in the future have cancer come back, or as you mentioned, might present for the first time, even with bleeding or pain, found to have a spread cancer. And so that collectively, whether it's grown from local and spread or started spread, is what we'd call kind of advanced or stage 4 disease. And that has greatly changed. I still think there's a role for all the stakeholders to be involved. Often these patients have a uro-oncologist who can help them even if complications come along the way, or in outstanding responses, which we'll get to, the radiation oncologist to help with any pain in an area that might be dealt with. But in general, it's largely the medical oncologists who are helping patients with advanced disease. For many years, we had chemotherapy as the main first tool. That got a bit better a few years ago when we showed, well, if you get chemotherapy and then the cancer stays stable or shrinks, you could add immunotherapy alongside. And now we've actually kind of totally upended the whole 50 years of bladder cancer by now doing combination immune therapy and antibody drug conjugates as first-line treatment. So
I have to explain antibody drug conjugates.
Sure, and it comes back to
in terms that my audience can understand.
It's really cool. So if you think about kind of the shape of Y as an antibody, and that antibody has a few components to it. One, it is seeking a target, right? So it's put in an IV and it's going to look for something. And in bladder cancer, urothelial cancer, that's Nectin-4, which is something that is widely expressed across urothelial cells.
It's a kind of protein that's on the cell. Right?
Exactly, you got it. Now, sometimes it overlaps with some skin cells, but in general, it's a very good marker for let's call it bladder cancer. So this antibody is seeking out, looking for that in the body. Now, that antibody is linked, has a linker to a backpack. That backpack has a drug that once the target is found, it will drop off that backpack at that cell, and that backpack consists of chemotherapy, in different forms. But you can imagine, and we'll talk about this particular treatment, but you can imagine there's different targets with different linkers and different backpacks. And in my other hat is drug development. We're thinking about lots of things we can do, but very simply, enfortumab vedotin is seeking out Nectin-4 and dropping off some chemotherapy when it finds those cells, called MMAE. And it's very, very cool. So it's, technically a form of chemotherapy, but has different tolerance, also given through an IV. And importantly, for stage 4 cancers, combined with immunotherapy called pembrolizumab, which I think probably your listeners and viewers have heard about before. But that is now the first-line treatment for a spread bladder cancer.
It's a remarkable development, all those different component parts. And I love the way you described it. The backpack it contains the chemotherapy it drops off.
Exactly.
It's a neat explanation. And something that becomes understandable to patients, because this isn't simple stuff for those who are not medical school trained sort of thing. So, yeah.
Who are, to understand it and get used to it and then explain it in a term that makes sense to patients rather than just some handouts, it takes time.
So does that mean if it's got that backpack and that tracker, that it's not affecting the rest of the body and just the cancer?
Yeah, so this is where it gets really technical, because yes, we would say it's better tolerated in the general sense than what we would say cisplatin chemotherapy, which is great, but it kind of, to use a term that some listeners and viewers might understand, is a little bit like napalm in the sense that it goes everywhere. That's fast to fighting, right? Whereas this treatment would target those cells. The issue, as I mentioned, is that target is also on skin cells. So it can, unsurprisingly, cause some skin reactions, which can be low grade, but it's the doctor's job who's administering this to understand, hey, it looks like there's a lot of spill in these skin cells. That might actually mean the drug is working quite well, but we need to help the patient to make sure it doesn't become a very large grade or spread rash. The other thing that these treatments can affect is a little bit of neuropathy as well, or kind of pins and needles feeling, but also how well the nerves function. So that's really important when you think about an age group that might be 70s or 80s. I think about the sensory neuropathy, the motor, the function, but also autonomic. When you stand up and you balance yourself, that's really important too. So the skin, I would say the nerves, and I would say even other things we look for is how does it metabolize and affects the liver a little bit. So we want to make sure our patients can be diabetic, how is their blood glucose control, and how are their liver function. But in general, I would say it is better tolerated, but you got to keep an eye out for some of these significant side effects.
And you're always using the immunotherapy with the antibody drug combination?
When it's the first treatment someone's had for a spread cancer, there's now data for that. But as you well know, the drug development would have started with this antibody drug conjugate. First development was when everything else had been used, meaning after chemo, after immunotherapy. Then the single drug was used, the antibody drug conjugate called enfortumab. But now it's gotten earlier in the metastatic or stage 4 setting to be the first option patients can avail of. And we're very lucky to have this approved in many parts of the world, US, Canada, elsewhere, and available. We're using it currently.
So you're involved in drug development. So where do you think we'll be in 10 years?
Yeah, it's cool. So to take a whole research program and try and distill it down in a few minutes, I would say there's two areas that are changing. One is how we are understanding the tissue we get from bladder cancer and what's driving someone's cancer is changing. So this is called kind of molecular underpinnings of cancer. So there are sometimes certain receptors like fibroblast growth factor receptor or FGFR that is upregulated in bladder cancer. We now have treatments for that. So lock-in key mechanism. If we find that lock, we can put a certain key. And so we are screening patients for that. That's really important. I think we are looking at bringing other antibody drug conjugates, so different targets, different backpacks in bladder cancer. And then I would say the real evolution might be just how do we use all of these in the right way earlier on in disease? We talked about muscle invasive bladder cancer where patients can still be hopefully cured, but we give them some treatment prior. I mentioned chemotherapy. Well, wouldn't you know it, there's already treatments looking at chemotherapy plus immunotherapy prior to surgery. So we're waiting on Canadian approval for that. And almost as soon as we get that, guess what? Trials are going to read out to show the immunotherapy plus the antibody drug conjugates prior to surgery. So that data is coming out. So you can see how
we see the evolution here.
And it is very possible that if we have folks that someone like Lorraine or our colleagues send to us for neoadjuvant treatment, that if we can give very good IV treatments, what if not only there's no spread, but the disease in that bladder were to melt away? How many patients can experience either a surgery even better or have their bladder maintained? These are all
that would be a great
thing. So I say it's the tools in the toolbox. We need to get more. And then when do we use those tools? Can we use it earlier in your disease? And that's what's really exciting. And my final pitch is even the non-muscle invasive setting where medical oncologists aren't in the mix. Well, wouldn't you know it? There's now data showing subcutaneous or injectable immunotherapy might be helpful for non-muscle invasive bladder cancer. We're going to get more data for that at conferences like the American Urology Association AUA meetings later this year. So can you imagine if we can get some subcutaneous injectable immunotherapy even earlier? Like you can see how everything is moving. And so I think bladder cancer is wonderful to study and to help patients. And I think all of our disciplines are working together.
Do you see some changes in the surgical approach or diagnostic approach from your perspective, Lorraine?
Well, I think we still need to get pathology. I mean,
you're not going to be put out of business, but
I don't
what is the
think so.
technique?
I don't think those, we still need to identify the cancer before we can treat it. And certainly having that tissue helps them to figure out their lock-in key mechanisms and their, where to send their backpacks. And so some of it is still tailored to patients. I think, it may be that if we have a really big aggressive cancer, we just get the bulk of it and don't go so deep as to potentially perforate the bladder. You don't have to be quite as aggressive with resection potentially if we can get their stuff to be.
We rely on some of the drug developments that are occurring.
The other thing that's pretty interesting, and I agree, I think the uro-oncologists, what they do, what they can see, that's such a cornerstone. But maybe one thing that could add to what the folks are doing is if we can look in the blood and find microscopic cancer cells, so circulating tumor DNA.
Right.
We're quite interested in that and trying to bring that into the Hamilton and McMaster ecosystem for these patients. But can we do a blood test after someone has had treatment or even had a surgery and reassure them that there's nothing microscopic in the blood? Could they avoid adjuvant immune therapy? Because I love giving these drugs. They can cause some side effects. And what if we knew that there was something in the blood before a CT scan showed it? So that's very cool stuff that I think I realize is not ready for prime time use today for our patients, but hopefully they take some hope that it might be on the horizon.
Well, I've heard a lot of hopeful things today, and I think it's been really a very useful discussion for people listening to hear about how bladder cancer can be detected, how it's initially managed and the various stages. But I'm particularly impressed by how quickly it seems to be evolving with the use of really exciting drug combinations and immunotherapy. It's really quite fascinating. You're working at a very interesting time. It's a good time to be in medicine looking after a disease like bladder cancer. I want to thank you both for your time and your expertise and talking to me about this and hopefully helping the people listening to understand better and to make sure they get good care, which is the number one thing we're concerned about. So thank you very much for your time.
Thanks for having us.
Thanks for having us.
Thank you for listening to the Cancer Assist podcast. Find more episodes, resources, and information at cancerassist.ca or follow the Cancer Assistance Program on Facebook, Twitter, and Instagram. Thanks for listening.